Okay, today's another day. We will be going back in Dr. Prepper and we'll be going through cases. A lot of the shorts that I've been making, and I've been posting them very, very frequently on YouTube Shorts, on Instagram Reels, and on TikTok. They've been doing quite well, especially the ones where I go through cases on my website, drprepper.co.uk. If you want to get started now, log on and I'll make your account free, at least for the first year while it's still up and running. While it's still up and running, hopefully it runs for many more years, hopefully. But yeah, I just think it's really, really good. I spent months making this during my final year of medical school. I've been updating it over this past few months of working as an F1, and I just think it's really good. So if you want to go on and get started, so let's just go through flick through a case again. So like you go Dr. Prepper or go to specialties, then just click which sort of case that you want to practice. I think I have over 100 cases alone for surgery, covering different topics in surgery: vascular, ortho, general surgery. But I'm just thinking endocrine and diabetes today because I'm working on endocrine and diabetes as part of my medicine placement in F1. So I'm thinking, let's go and let's get started doing this. Let's start. So we have a young man with muscle cramps and tingling hands. Ooh, just based off of these symptoms, what are you guys thinking so far? Because this is quite an interesting case. This could be one of like 2 or 3 conditions just so far. So a 33-year-old man comes in with numbness and tingling around his mouth, hands and feet, along with painful muscle cramps and twitching. He underwent total thyroidectomy 3 weeks ago for a large multinodular goiter. Since the surgery, has felt generally unwell with intermittent palpitations, muscle stiffness, and occasional spasms in his hand. He denies any fever, seizures, or visual changes. He has no prior history of neuromuscular conditions or psychiatric illnesses. On examination, he's anxious and fidgety. There's a positive Chauvet-Tex and Trousseau's sign. I still don't know how to say that properly. Indicating neuromuscular irritability. His pulse is regular, BP normal, and there are no signs of infection or inflammation. So a 33-year-old man with perioral tingling, hand cramp, and muscle stiffness. No recent thyroidectomy 3 weeks ago. No previous neuromuscular issues or seizures. Denies alcohol, drug use, or trauma. Reports occasional palpitations and mood swings. No family issue. Blah, blah, blah. So we have here. What are we thinking is going on? These are the clinical findings. Positive Chauvet-Tex sign and Trousseau sign. Mild hand spasm observed. Heart rate, no thyroid swelling, no lymphadenopathy. What is your differential diagnosis? Let's go through the scoring guide. I'm thinking first of all, it's something to do with his total thyroidectomy. First of all, these signs here are they're seen in a hypocalcemia, but I guess the thing is hypocalcemia is secondary to what? As he's had his thyroids removed, I assume it's hypocalcemia secondary to hypoparathyroidism. Some other things to think of is maybe some other electrolyte abnormalities like again, I don't know how to spell this properly, hypomagnesemia. Then maybe if you're thinking something else, maybe seizures, like focal seizures, but I don't really think that's the case. It's a lot lower on my differential list. Thyroidectomy, no previous muscular issues, no history of seizures as well, which rules that out, but I'll just have it down there in case. I like to do an ECG as well, but there's no need because his heart rate is fine. Palpitations. So, he has intermittent palpitations, muscle stiffness, and occasional spasms in his hand. So some form of spasticity in his hand, but been going on for 3 weeks. I'm not really thinking it's anything like severe. Let's see what the answer is. Post-surgical hypocalcemia, most likely given his history. Yes, secondary to hypoparathyroidism, secondary to surgery. With vitamin C, vitamin D deficiency. Ooh, that's another cause of hypocalcemia. That's very good. And pseudo hypoparathyroidism, unlikely without because the features. Ooh, this is not too bad. So this one I'll give myself a score of like 1 because I've already gotten one of these. Oof, we're not starting off good. Investigations. Enter top 3 investigations. To investigate this, the vitamin D, calcium. What else would you want to do? Maybe ECG because he mentioned palpitations. What did they say? Muscle stiffness. I don't think we need to do any sort of scan, right? These are the key tests that I'll do. Some other like generic tests to look out for, maybe FBCs to look for signs of like anemia, baseline OBS. But we already have the OBS over there. don't really think there's anything else I do, like an ultrasound or anything like that. I think of vitamin D, maybe PTH as well, since I was thinking hypoparathyroidism. We have calcium, ECG. I think that's pretty much it I'm thinking so far. PTH, magnesium, vitamin D levels, ECG, renal function, albumin. Yeah, so using these as well would have been good to add in. But so far I'm thinking like that's like what, 2? I'm thinking that's 2 at least. A management plan for this is so assuming it's not due to vitamin D deficiency, it just most likely needs calcium replacement. You know, add cal or IV calcium, just like depending if we on like how low it is, if it's mild, moderate, or severe calcium deficiency. Counsel the patients. I'll probably let my senior know as well. So escalate to my senior. So counsel the patient on hypocalcemia. And inform senior. Okay, that looks good to me. Conservative management, so diet advice. Diet advice and safety net to patients. On like if there's any worsening of their symptoms, any worsening spasms, if it's not controlled once his calcium is replaced, if there's any like seizure type activity, loss of consciousness, very unlikely, but just in case that happens, any other like increased symptoms of and palpitations or irregular heart rhythm, then come back in. Yes. Okay, yeah, so I guess, yeah, in this case, since it's symptomatic, so you just go straight to IV. Calcium gluconate, long-term oral calcium supplements, activated vitamin D, monitor calcium, phosphate, magnesium, endocrine referral. That's a very good one for long-term management, and educate patients on symptom management. So I have like at least 3 of these. I'm going to give myself a 3, but the key thing here I think would be endocrine referral. And then in terms of high-yield information, hypocalcemia following thyroid or parathyroid surgery is most often due to accidental removal or devascularization of parathyroid glands. The hallmark signs include perioral, fingertip paresthesia, muscle cramps, carbopedospasm, and in severe cases, and tetany seizures. Shorttext and true signs are clinical indicators of neuromuscular irritability. ECG changes include prolonged QT interval, which can predispose to arrhythmias. Initial management requires urgent correction with IV calcium gluconate. In severe or symptomatic cases, maintenance involves oral calcium and active vitamin D analogs to prevent hypocalcemia. Patients must be educated to recognize early symptoms and carry a medical alert identification. Chronic hyperparathyroidism will lead to cataracts, basic ganglia and classifications, and neuropsychiatric symptoms. Careful monitoring is essential to avoid overt treatment, which can cause hypercalciuria, nephrocalcinosis, and renal stones. In some cases, recombinant human PTH is used in refractory cases. Magnesium deficiency must be corrected to allow proper PTH function. The differential includes vitamin D deficiency, acute pancreatitis, CKD, and sepsis. Post-surgical patients require lifelong follow-up, and quality of life may be impacted by persistent symptoms. The risk of permanent hyperparathyroidism is higher in total thyroidectomy versus hemithyroidectomy. Multidisciplinary team care, including surgery, endocrinology, and specialist nurses, ensure best outcomes. Timely recognition and prompt management prevents potentially life-threatening complications. And that is it. And after you've done that, you can click to save your answers. And if you want, you can also click to reset the case in case you don't want this to be saved and you want to go through and redo all these cases again. And also like leave a nice little comment. I mean, ideally something nice down below just to let me know what's going on and what you're thinking. But yeah, that is it for this case. We should probably move on and do another. I think we could probably squeeze in one more. Okay. Let's see. What are we doing now? Hematology. Because I've been seeing a lot of our patients, well, not our patients, a lot of patients on the ward, they low-key come in. They're low-key being seen by heme team as well. I find it quite interesting. A woman with numbness and tongue changes. A 72-year-old woman presents with progressive numbness and tingling in her hands and feet, unsteadiness while walking, increasing fatigue over the past few months. She also complains of red, sore tongue, and occasional memory lapses. She denies weight loss, fever, bleeding, no history of vegetarianism or significant alcohol use. Past history includes hypertension and osteoarthritis. She is not on any regular medication other than paracetamol. On examination, she appears pale, with a smooth, shiny tongue and loss of proprioception in both lower limbs. Reflexes are sluggish. Romberg's test is positive. She is worried about the possibility of a neurological disorder. So here we have a 70-year-old woman with numbness, unsteadiness, and fatigue over a month. I'm not even going to lie. I'm reading this right now. I have no idea what's going on. Let's actually lock in. So she has a sore red tongue. Actually, no, I think I do now. Sore red tongue and memory issues. No alcohol use. No family neurological disease. No bleeding or weight loss. No hypertension and osteoarthritis. Concerned about neurological decline. And she has pallor and a smooth white tongue. Impaired proprioception and reflexes. Positive Romberg's test. These are some very, very key signs. Scoring guide again. 0, 1, 2, 3. Just read through that. Helps you score your answers. Right now I'm thinking the vitamin B12 deficiency, which is potentially going to lead to like subacute degeneration of the cord. Just by that smooth red tongue. Something else I'm thinking about is classic anemia, just due to the tiredness and fatigue, and her age. Numbness, I'm thinking similar to the previous case. I left. Actually, let me be more specific. Iron deficiency, anemia, I'm thinking. And then the third one, it was an electrolyte abnormality. For example, like hypomagnesemia. Just due to those symptoms over there. Increased fatigue. I was going to say cancer, but seeming like there's no bleeding, no weight loss, no family of neurological disease. I'm less likely to think some form of cancer, no history of vegetarianism or significant alcohol use. Because if I was thinking of, a positive Romberg's test, I'll be looking up, does she have history of alcohol use? Not negatively with medication, very smooth, tongue, loss of proprioception. I think that's what walking. Oh, I guess another common one, just due to her age, is stroke. Let's see what's going on here. Peripheral neuropathy, cervical myelopathy, epidoticus. Oh, I'm only getting one again. Cervical myelopathy to exclude with after imaging. Oh, okay. Well, at least I got the main one. Vitamin B12 deficiency, neurological and hematological features. So I guess again I'm getting a score of 1 for this. But I'm happy with these ones. Iron deficiency, electrolyte abnormality, stroke. But I guess peripheral neuropathy, cervical myelopathy would be good to exclude. Investigations, FBC, UNE. So look for anemia and look for electrolyte abnormalities. I'm not worried about infection, am I? I don't think her temperature. They didn't give us anything in terms of temperature. But she has no fever. She just has, there's no fever or weight loss. I would like to get some based on those. If I'm worried about cervical myelopathy, maybe CT, MRI, neck. Obviously, I would discuss with my senior. I also like to do ATE assessment of her. Full neurological exam. So as you can have done one. I want to do a stroke assessment. Just in case I'm worried about that. Stroke bloods, like lipid and all that. Season CRP. Yeah, that's what they're saying. B12 on folic is good to add in. I didn't even put in B12. Which would, okay. But from pap smear is heme, so pap smear, haploid neutrophils, methylamic acid, homocysteine elevated. Ooh, Coombs test exclude hemolysis. Very, very good test. Okay, and consider intrinsic factor antibodies of promiscuous anemia suspected. Oof. Okay, yeah, see, these are much better differentials. I'm putting a 0 for that one. Maybe strict, actually, no. I'm putting 0. Management includes vitamin B12 replacements, patient education, escalates to senior, especially if you're thinking of something like stroke, or if you're thinking subacute degeneration of the cord. What else are we thinking? These neurological and pathological features. We could look to do imaging after discuss the senior. I don't know if imaging would be needed in this case. So what was it? Interpretation of B12 investment, which is intramuscular injections, treat online calls, monitor blood counts, neurological symptoms, dietary advice, regular follow-up for neurological development. I'll give myself a T for that one. Follow-up, and a good thing to mention as well is follow-up. Now let's look at high-yield information. Vitamin B12 deficiency causes megaloblastic anemia and neurological symptoms like neuropathy and cognitive decline. Common causes include pernicious anemia, dietary deficiency, malabsorption, macrocytic anemia with hypersegmented neutrophils as characteristic. Neuroinvolvements may be irreversible if treatment delayed. Diagnosis involves low serum B12 and elevated methylmalonic acid. Treatment requires parental B12 initially due to absorption issues. Monitoring for hematological and neurological recovery is essential. Pernicious anemia is autoimmune, often associated with other autoimmune diseases. Early recognition prevents irreversible neurological damage. Okay. That's good. We can save our answers and then we can go on. What is the last case that we're going to do, guys? Okay, I want to go back. What is the last case we're going to do? I'm just going to like close my eyes, flip through, click one, flip through, and click this one. So we don't know what specialty this is. Patients with recurrent abdominal pain and altered bowel habits. Ooh, this seems classic. Very, very classic. 38-year-old woman presents with recurrent episodes of cramping and abdominal pain for 6 months. The pain is localized to the lower abdomen, often associated with changes in bowel habits, including alternating constipation and diarrhea. She reports occasional mucus in her stools, but no blood. No significant weight loss or fever. Past medical history is unremarkable. No family history of colorectal cancer or IBD. She denies recent travel or antibiotic use. The symptoms interfere with daily activities and cause distress. No vomiting or nausea reported. So we have a 38-year-old woman with 6 months of intermittent cramping, lower abdominal pain associated with alternating constipation and diarrhea, occasional mucus and stool, no blood noted, no significant weight loss or fever, no family history of colorectal disease, no recent travel or antibiotic use, symptoms of periodic activities, mild tenderness in lower abdomen, no gradual rebound tenderness, normal bowel sounds, no palpable masses, vital signs stable, no perianal abnormalities, no signs of systemic disease. Again, scoring guide 0, 1, 2, 3, depending on how good your answers are. Differential diagnosis. I think one thing I saw here was like there was no family history of IBD or something like that, right? No family history of colorectal cancer or IBD, but still, I'm seeing mucus in the stool, 6 months. Nope, no palpable masses. I'm thinking it's some form of IBD versus IBS. Okay? With IBD including things like Crohn's or what's the other one called? The other one has left my head completely. It's left my head. It's completely left my head. Crohn's was IBD, and then a lot lower on my list because there's not really much family history or red flag symptoms of cancer, but bowel cancer, I just have to have that down there. And celiac is all the way up there. Oh, what is all the IBD? It's completely left my head. But it will come back. You know, it's confined to the latter end of the large bowel. You also see a lot of mucus and stool. It doesn't have skip lesions like Crohn's disease. ulcerative colitis. The IBS, chronic pain while there's no alarm features, IBD considered bleeding symptoms, colorectal cancer. Lovely, we are getting 3. At least we'll end this section strong. We're getting 3 for this one. We are getting 3. Investigations to look into this. FBC to look for anemia, or maybe raised blood cell count if you're worried about infection. I like to put in using knee just to look for electrolyte abnormalities, see if there's been any dehydration as well, or loss of you know, sodium or like potassium or magnesium from you know, frequent diarrhea. Sorry, the screen lagged there for a second. Let me make sure it's still recording. Oh my days, it stops recording. Okay, it stopped recording. Okay, and we're back. So what else would I want to do? If I was worried about IBD, fecal calprotectin, if I were worried about bowel cancer, fit test, abdo X-ray, abdo ultrasound / abdo X-ray, CTAP after I discuss with my senior, because they could probably veto that, especially if it's IBS. They probably won't want to do all of this extra imaging. We've done an abdo exam already, so we have baseline abs already. There's no vomiting, no diarrhea, so nothing to do there. There's no blood as well, but I'm still doing a fit test just because of this. Yeah, that's what this is. Stools infection, stool studies as well. Oh, that's a good one. Stool culture, C. diff as well, maybe. Colonoscopy vindicated by symptoms. Abdo ultrasound includes structural and celiac serology as well for gluten sensitivity. CFTs, imaging CT, malignancy expected. I still see at least 3 of them there. Like this one here. Oh, maybe 2. Management plan for is patient education. If we're thinking it's IBS, maybe frequent monitoring of symptoms, to tell the patient, you know, to be aware of their symptoms and what to do if it changes. Maybe to come back in like a couple of months again for a checkup. Safety net them on the red flags to look out for. Blood, increased mucus, pain, maybe feeling of incomplete emptying. Maybe book an outpatient colonoscopy if that's indicated. Maybe if you even got like maybe if you referred to general surgery and they requested a follow-up as well. If you refer to general surgery, clashed, you may also want an outpatient general surgery clinic appointment. The only reason I know this is because I literally worked in here for my first job. General surgery follow-ups, which could be a telephone call or not, or in person. And maybe symptom management with Buscopan. Buscopan pain relief, like paracetamol, diet habits, especially especially in case of if it's celiac. We're doing pretty good, we're doing pretty good. Let's see what I have here. FBC, Inflammatory America, CRP. Okay, I have that earlier on, that's more investigations. Two study infection, colonoscopy vindicated. Abdominal sound, celiac surgery, CT, as expected. Oh, it's pretty much the same thing. Oh, I mean, they need to change this to make sure everything is work. Let me see if there's any change here. Recurrent abdominal pain with altered bowel habits can be functional or organic. Irritable bowel syndrome is common and undiagnosed clinically. IBD requires early identification and treatment to prevent complications. Colonoscopy helps differentiate causes. Diet and lifestyle changes improve symptoms. Ooh, just good as well for management, diet and lifestyle. Psychological factors may play a role in functional disorders. Patient education enhances adherence and coping. Monitoring disease progression is essential. Exclude malignancy in older patients or those with alarm features. Multidisciplinary care optimizes outcomes. Alright, save our answers. That's it for this, guys. Hope you enjoyed this video. If you want me to do more of these, then let me know. If you want to practice, then go on Dr. Prepper yourself, drprepper.co.uk. Get practicing with these cases. There's over 500 cases. We can see my average scores increase. My highest score now 78%. We're getting there. We're increasing. This is like case completion tracker, 23%. So we're slowly working through these cases. There's a lot more to do, and here's just some, like, here's what Dr. Prepper is, and here's some feedback. So if you want to really get involved, then go now and get involved, see these cases, and let me know what you think I can do to improve it. If you log on, I'll make your account free forever, so especially in this first year of Dr. Prepper's launch. Go there, let me know what you think, and I'll see you guys in the next video. Goodbye.